Liselotte Schirakow and Inge Bjerregaard, and they are a clinical midwife specialist and a physical therapist who are here to share their knowledge about fatigue, physical activity, and quality of life. So it is my pleasure to warmly welcome you to the stage. Okay, let me see if we can exit the presentation mode. Sorry. Okay, let's do this. And go to here. I think I solved it like that. Yeah. Here we go. You're welcome.
Okay, thank you very much. I'm here, invited from Liselotte last week. So I've been very concerned about can I get enough to talk about? And the persons who have been here before me, it's the ones I've learned from. So this is very exciting, but we'll see how it goes. And we'll start with a little presentation. I'm a physiotherapist in the National Rehabilitation Center for Neuromuscular Diseases in Denmark. And just telling a little about where we work. We are a hospital, but we have no beds and we make no treatments. It's a neurologist at the hospital and the physios on the clinics. So we are somewhere in between. We don't have beds. We are founded by the Danish Patient Organization for Neuromuscular Diseases and Muskelsvindfonden in 76, and we are funded by the Danish regions, and all services are free, both for the patients but also for the communes, schools, kindergartens, social workers who works out in the community. We're a national center with departments in Aarhus and in Høje Taastrup. It's the pictures you see. I'm working in Høje Taastrup. It's a beautiful place, and you are welcome to come and see it if you are in that in that part of Denmark. We are a multi-professional team consisting of physicians, nurses, occupational therapists, physios, social workers, and psychologists. And what's really nice about working there. And we can see, if we think about the map that was shown previously, we represent the rehabilitation part. All patients who get a neuromuscular diagnosis can be referred to the center, and we have approximately 3,700 patients, 40 diagnoses, and 100 genetic subtypes. Often if people hear about neuromuscular diseases, they think about people using a wheelchair, but as you know, it's not always like that, not at all. And we work together with Muskelsvindfonden, and Liselotte is, how would you say?
Well, Niels Erik, you called me 2 years ago to be a patient expert, so I'm using that term. I have MG myself and is a member of the MG Association in Denmark, and we are underneath the umbrella of Muskelsvindfonden. So when Inge has a patient with MG, she can say to them, okay, you have to go to Muskelsvindfonden to get the patient view, and she is the physio and anything about rehabilitation, but we work together and know the patients that we both have.
And what about being MD patients in rehabilitation center? They're referred by neurologists, typically from a specialized hospital in Denmark. And the patients, they may not be stable, but they have started on medical treatment. And they assume that then they need maybe social counseling, psychological help in dealing with all that is difficult by getting a new diagnosis. They might need advice on energy managing, and it's our occupational therapist, I should just remember the word, and advices about training and physical activity. And we are very pleased about the new guidelines because it's much easier to tell people that we want them to exercise. Patients are often physicians are often explain about different health problems and side effects related to medical treatment. And we should talk about fatigue. I know Linda has written in her PhD about fatigue and emphasizes this is a very big problem. And she says in her article, fatigue can be categorized into peripheral and central fatigue. And that's what it's been talked a lot about today. Both muscle fatigability is found in patients with MG, when we know it all about suddenly the muscles can't work anymore, and central fatigue, and it's a subjective sense of fatigue, including both cognitive and mental fatigue. And it's so easy for the patients to be misunderstood when they're talking to the social workers, talking to the family and to their friends. That's a great problem that we meet. And what she says, it's higher levels of physical activity has been associated with lower levels of fatigue. Here again, it's good to be a physiotherapist. What we also hear about is pain, and it could be muscle pain, joint pain, and headache. I'll get back to this.
Many of us know that the fatigue is a symptom, and we like the questionnaire about fatigue because that's visible for the neurologist and the physios to see, okay, what's the problem about? And that's also one of the main reasons that we are a bit reluctant to make physical activity, because we know that it's good for the body, but we also know that we have to feel the fatigue more than just the everyday person who is active. So sometimes if you do too much of activity, you get the strain of the muscles that maybe mean that you cannot walk out of the training center, or you have to relax for an hour before you can go home or drive home, or take a power nap, or whatever means necessary for you to come all the way home again. But as Anna also said, it's not dangerous, it's just fatigue, and we have to remember that.
It's good to know it's not dangerous, at least. A few weeks ago, I met a man. He was 59 years old, and he was diagnosed in 2013, and he had just been told that he could have early retirement. So he was told the same morning, so it was a quite new situation for him. He had pain, especially in his knees, because of he has had a hard working life, and he had been doing a lot of sports. And he felt a lot of fatigue. And now I think it comes here. Yes, that's what he was feeling. And he was missing being physically active, and he had been playing football. He wanted so much to play football again. And he talked about if that should be possible. He had some friends who were trainers for small kids, and he wanted to participate. And that was how he could see himself. And he said, maybe I could bring a chair and I could sit there and I could give advices to these small kids. So that was a way of coming around about his fatigue, because he knew he needed to sit down sometimes. And he wanted to go swimming, the little duck. And being a father, he had a daughter, 16 years old. He wanted to participate more in her life, being active, going to vacancies. And we talked about how could he do it? Could he maybe bring some sort of scooter? And that's very hard for many people to accept. It is necessary to use some mobility aids, but it could be a possibility. And he talked about economy was a problem for him, because he always thought about what's next, what must I try to do working, and I know I can't afford it. He was 3 days a week, 5 hours, and that was too much. So it gave him a new life, being able to see he could care for himself. And overweight, he had gained a lot of weight during the last years because he didn't have the energy to do some exercises. An Australian study talks about the research of the study, concluded that there were clear enablers and barriers for coping with MG. The enablers were social support, as a very important thing, and medical management. The barriers were fatigue and pain. And what we see when meeting the patients, maybe they say, I can't keep my eyes open, double vision, hard to eat and talk, hard to hold my head while sitting. I've been looking around. I think somebody has needed to have a hand under the chin, and had to stand up for a long time, walk, and sit upright. So that's what we need, and somebody's laughing, maybe recognizing. And what do the patients say in this research? Their experiences with health professionals were considered insufficient and failed to provide disease-specific advice regarding MG and physical training, and that's not so good. We want the patients to exercise, but we are not good at it. Okay, what should we do? My suggest, and in the article as well, the physio must have sufficient knowledge about MG, and the guidelines are good at that point. The physios must provide tailored physical activity, and that's what you talked about. Sometimes it's fine doing the exercises together with others because you get the social element, but sometimes you need someone just telling you what to do. Oh no, you shouldn't do that. Just change it a little, and may the patient feel secure, safe, encouraged to do just a little bit more. And listen and support and gently push to obtain self-efficacy. So it's very small steps, and sometimes maybe step a little backwards. And be aware of the need of interdisciplinary approach. Maybe you should not exercise right now. The economy is too pressed, and you may not be present with your children, your grandchildren, so maybe we should talk to our social worker, our occupational therapist, if they have suggestion about what to do now.
5 years ago, I suddenly couldn't walk, and I thought it was my MG just acting up, having a flare or whatever. Instead, and I got on sick leave, of course. But then on sick leave, I started training to get my wheels turning again. And I trained with a physio, not a lot of knowledge about MG, but she was willing to get the knowledge. So she got into the exam room with me, and we did an individual training. So as you can see now, I'm walking without anything. It's troubling at some times, but now I've also started working again, and I had to find a way to combine my work and my training, because it takes a lot of energy to have the work and family and whatnot, all the work I do here as well. But the main thing is that I find a way. It's individual. It's for me. It works for me. We have a lot of new apps going around, exercising with small exercises. You can do 5 or 10, or you can do 30 seconds or 20 seconds or whatever. But it says, like in this, you get a little push from the app. You can do this, and 3 seconds, and now you're done. So it goes in some way. And for me, it works, because I don't have to go to a gym and use my energy to go there and go back. I can do it at home. And I don't have to shower and get dressed or whatever you have to do when you have to look nice in a gym. Yes. So it saves my energy, and it builds muscle strain, and it builds my capability for standing up straight and using my core physio. So it's just to let you know, there is a tale about every one of us with MG, and you have to find the way that's suited for you to do it the best way for you as a person.
And what should we be aware of as a physiotherapist? Cardio and muscle strength exercises, respiratory function, joint mobility, bulbar function, fascial muscles, energy managing according to physical activity, and ADL. So, a lot to do. This is recommendations for physical activity. Anna has told about it, so I won't go further into it. But when I show this one to the patients, they say, wow, this is not possible. And anyone else, I think, sitting here, not having the disease, thinks, how to get time for that? So that is a gold standard, I should say. And thank you for this. I have borrowed it, and I use it sometimes to, when I talk to physiotherapists, saying this is one way you could make a program, being sure you train all parts of your body, and maybe not 2-3 times, 10-12 times, 2-3 sets, that's not important, but go through the whole and do the changes between, so the muscle groups have a rest. That's to avoid being exhausted. But we can't do that to all our patients. And we had a very clever man in the Rehabilitation Center, Asger, who talked about the waiting room, which was the time from being diagnosed till you were treated and you were quite stable. There was so much insecurity in that period of time. So what could we do there? Maybe we could do some breathing exercises. There has been a research about doing some breathing exercises before operation of pneumonia. And I would just wonder, maybe we could we use that for people being not being a little stable, start very carefully. I just wonder, I don't know, maybe the doctors would say something else, Cycling, if you feel safe, if you have done that before, and sing loudly and continue for a long time. We've had a physio talking about singing for a group of other kinds of neuromuscular diseases, and when they've been training, they were very exhausted actually, and it has a good effect on the respiratory function. So it might be in a choir, it could be standing in the shower, anywhere. You don't have to dress or undress. Daily tasks in the house and garden just to get up, and it could be other forms of movements where the heart rate raises above resting level. So that's not much, but just a little bit.
And the daily task, you don't have to vacuum or take the washing of the floors or anything like that. Do small things, because the other stuff is hard work, and it takes a lot of energy, and it's a lot of repeated function. So do small things that's not repeated function, but exercise a little.
Yes, and maybe you need help for those things in a period of time, and you can apply for that. At least in Denmark, I don't know in the other countries. If you're medically stable and it's mild to moderate MG, it's a cardio training like talked about previously, like circuit training, daily activity with the heart rate above level, training with high heart rate for minimum 20 minutes, at minimum 3 times a week. Also good if it's performed as interval training, so you get the rest between. I think about the respiration, what's important, it's talking about posture, because if you're weak in your core muscles, you tend to, I'm a physicist, but I have to show, sink a little, bend down in your knees, and if you do that a lot, maybe you get too short in your hamstrings, and if you do that, maybe you need some strengthening to get the right posture, and it's also in the neck for the respiratory muscles to work efficient. So that's what we work a lot about, or talk a lot about. The neck we talk often about, because the neck is often bended backwards. When we have courses, people get tired and sit like this or like that. So strengthening...
Even the doctors.
Strengthening these muscles are important as well as the big muscles we've been talking about. And talking about position, making this movement is a little exercise that is very important, and also for eating, for talking. So it's another point of interest. And flexibility of the chest. If you are very protracted like this, your respiration may not be deep, and you don't get enough oxygen. So open up is very good for the respiration and for the energy. And anxiety that many people feel can also cause more tone in those muscles I talked about, both in the chest and at the pelvis. Balance. I've been told I've not much time left, so I just hurry a little now. Balance, and it's also about posture. If you want to have a good balance, you shouldn't just stand at one leg training. It's doing it functionally. Have to change position. Maybe working like here. Maybe turnarounds. Maybe playing with a ball to make the body flexible, and it has to be strong as well to have a good balance.
I do horseback riding for 1 hour each week. It's a physio. It's not just me going out on the hills. You can do that in Iceland with your horses. They are very nice. But you have to find the right horse for you, because all horses have different styles. So if it's too strong for you on the back, you have to find a horse with longer legs or whatever to have a smaller figure. But it helps. It has shifted my headache from every day to none at all.
And she's an expert, not only midwife, but also in horse riding. And a question about that I'm very interested in. I don't know if it's possible. Can training of these muscles lead to improved function, about the bulbar function? We do the guiding about sitting position, like I talked about, while eating, advice on chewing and swallowing, not too big bites at a time, not talking too much while eating, consistency of the food, or maybe having a rest before eating with others, or longer conversations, because then you have more energy, your muscles are not tired. And you can see the advices at this link. Do you have problems with eating and drinking? At our homepage. And what activity to suggest? Avoid extended sedentary time. Shouldn't sit too much, just to get up and do a little. If you have an appointment with a friend, you get out so you don't sit that much in your everyday life. So that's a little change maybe for some people. As Sheem, be aware of what takes your energy or what gives you energy. Can you do an activity maybe for half an hour, it gives you energy? If you do the same activity for 1.5 hours, it takes your energy. So be aware of it, making a scheme where you put in maybe just 10 minutes by time or 15 minutes. Training diary, maybe together with your physio, social interaction while training, and focus on interests. Is it possible to do things in a different way? If you like to go on a kayak, maybe you can do it in a double kayak. So the person on the back can do most of the work. And thank you very much for your attention.
Thank you so much. I think that we give Denmark 12 points from Iceland for this presentation. I am sure you have many questions for our wonderful presenters. Is there anyone who would like to start? Yes?
Christopher, if you are low on energy, but want to behold your holde din muskelstatus, ikke gå nedad, men du har ikke meget energi. Hvilken øvelse er det bedst til dig?
I think there's not one answer to that, because you have to do the tailored exercising in that respect. Because I think people are affected differently and react differently. But I think what is doing some exercising about posture could be a good way of starting, because it's not exhausting in the same way as using the big muscle groups.
And that's just Inge, because it is exhausting. So, but it's easier than the big muscle groups. So you have to think about how to do it and start small. Just tiny necks you can start with, and then you will find that you get the muscle strength to do more. So you just have to start.
And sometimes if I feel people are too tired, it's much too exhausting to do the exercising, I call Runa, my colleague, or some of her colleagues, and talk about how do you spare energy, how do you do things at home in a better way, work smarter, not harder.
For example, I have trouble walking, but I still do the training on the floor with all muscle groups. But instead of walking long distances, I have a wheelchair that I use for the long walks with the dog and boys and stuff. But so I save my energy for the training, and then the walks I can just get along as well.
May I ask you about the National Rehabilitation Center that you're part of? How do you think that Myasthenia Gravis compete with all the other diagnoses in the National Rehabilitation Center? I have the feeling, for example, in the Norwegian patient organization, the focus is on the rare genetic disorders where children and others are dying or they become very weak. Do you really concentrate on Myasthenia Gravis at the rehabilitation center? And how should we as a patient community have a strong enough impact in the National Rehabilitation Center? And how do they do it in Denmark? And how could we do it in Norway and the other countries to have this impact? Or is it nice to be within a neuromuscular group? Or should Myasthenia Gravis be a separate group, fight for themselves in some connections? Or are we better off together with other strong partners? Do you have any views on that?
Yes, I have many. Yes, I think it's very interesting working with Myasthenia Gravis. And I'm so pleased with you. You have made the guidelines because this makes it more easy to help this group of patients. And I think it's okay being in the rehabilitation center. I think it's a good idea because there are so many things people with neuromuscular diseases have in common about sparing energy, about using mobility aids, about being tired. Maybe not like MG, but some others do have the same problems. So that's what we see very often. We see people fighting to stay at work, needing help at home. So very, very much is the same needs. So I think it's a good place because we work with rehabilitation and it's not just one or two diagnoses. So our thinking about rehabilitation in MG, I think is very useful. And please invite us because we want to learn more and give out from our experiences.
Thank you. That was an excellent talk. So I thought about two things, Liselotte, what you said. So I think one point is really important. Not everything in MG is MG. So what you said about this fatigue that can be triggered in period, we have a lot of women who are mothers and who have small children and who have house chores. And, that can also trigger a fatigue which is not physically related to MG. Just to point that out, I thought it was really good, you pointed it out. And one more thing, so in our Swedish study where we had patients now with the digital Oura Ring, we noticed a lot of women were horseback riding. So we didn't know this, so I don't know if that's the same. When you said that now, I was laughing a little bit because we had no idea so many women with MG in Sweden were doing actually riding and having horses. And they were quite exhausted, but it's a very heavy thing, right? To ride a horse and to take care about the horse and they spend many, many hours in the stable. So we should not underestimate this activity. That would be an interesting study in itself. MG patients who are horseback riding, because I had no idea about this before our study. I don't know if that's just a chance or if it has some real association.
So horse riding people get MG?
Can't even compare tult with the other ways of riding and see if there was any difference. No, I agree very much what you all say, and I think it's so. In a way, your response regarding this national rehabilitation, neurorehabilitation part is, I think, it's a message to the myasthenia gravis patients and doctors that we should use the strong organization. So we should it's our responsibility, both doctors and patients, in a way to use and to influence, for example, the Norwegian Muscle Association and the rehabilitation systems with myasthenia, as they probably have done in Denmark, that you say that you are really interested in. I think because it is an interesting disease. It is a very nice group of patients, but it's up to us to in a way to show up and to use these resources that probably are available in all the Nordic countries.
The MG work group has been a part of the Muskelsvindfonden for over 40 years in Denmark. So we have a lot of experience combining our knowledge with the other neuromuscular diseases and the Rehabilitation Center working together. So it's only a win-win. We win together when we are more.
And we are very aware about, for example, being an elderly people, because we have courses for people, seniors, where we talk about some of these problems, and it can be people with all kinds of neurology diseases, and very much similar. Also about identity and self-feeling.
First, two comments. One is I very much agree with both Anna and Niels-Erik about these issues, and I think that we could still work on to get a closer collaboration between the Rehabilitation Center and all the resources there and the resources at the neurological department. So I think that's actually a very good thing to go into and have a dialogue about. Another comment is on the exercise part. This is just a comment on remembering also the mental and psychological aspects of this. There might be a mild depression or even a moderate to severe depression sometimes. And I think that as physicians, we have to take care of that. That might impair their ability to go into exercises. Another aspect is obesity, overweight, which I think is quite a problem, especially in the elderly MG patients. And I think sometimes they refuse simply to do exercise because of the inconveniences and the pain that may occur during exercise due to even severe obesity. And now we have drugs, as you know, the Novo drugs and others that can actually take care of obesity. And I think we should look more into that. I think it's a big problem.
Yes, it is.
Does that conclude our discussion, it seems? Well then, wonderful. I would like to warmly thank our Danish duet. Thank you so much.